Joining me to host this Tell Me More About session is Markus Hürzeler. Good evening and welcome, Markus.
Good evening, Gerrit. Nice to be here.
Yeah, glad to have you here at the final part of our program here on the first day. Today we talk about whether 3D radiography is mandatory in treatment planning. Now, you started to use navigation in implant dentistry already 25 years ago, and in that time gained experience with both online and offline navigation.
That's true, Gerrit. A long time, I see, but gives me a lot of experience with all this
Exactly.
new technology.
Exactly. It's a long time, and we are very proud to have all that experience here in our program today. Earlier today, you chaired an on-site session here in Geneva together with Andrew Dawood. And based on that session and your learnings in those 25 years, you can tell us more about why you believe that 3D radiography offers such an opportunity that it should even become mandatory. Can you introduce us into the topic?
Yes, that's actually a very hard word, I would say. Mandatory is really something we actually maybe discuss afterwards. But what I can say with my own experience, I think it becomes more and more a very, very important tool of implant therapy today. And let me now share with you a little bit our thoughts, and especially it's more the patient, you know. When we look at the patient, they have today clearly wishes and expectation to our implant therapy we are going to do. It's not anymore discussion, does an implant integrate into the bone? Or does it look more or less okay? It's about what does the patient really want from us? So if we go now on the street together here in Geneva and we ask any person and say, what is the problem with implant, dental implant? They will tell you it costs a lot. It is very painful. It lasts long. So there are still a lot of problems we have in modern implant therapy. And this is why I think this new technology will help us. So yes, at the beginning, we thought, yes, this new technology helps us to place the implant in the right position, which is important, no doubt, in the position three-dimensionally. And we have now this opportunity to get there much closer than when we do it free-handed. But very experienced guy will tell you, come on, I don't need that. I'm now placing implants 30 years, so I don't need a template or a navigation dynamic with 3D analysis. This is not important for me. Maybe yes, in this indication, yes. But what I can see, just with my introduction I gave you, there are now technology we can use and treat patients in a sense that we can fulfill more their request. So let's have a look at the patient. When we look at this patient here, she has lost 2 teeth in the aesthetic zone. And when we go now back to our approach, we do normally in a case like this, we place an implant, we do soft tissue management, maybe we have to do 2 or 3 surgery to get a final result in a case like this. If I tell you now, a patient like this today, we can treat within 2 sessions in our clinic. So this allows us a new technology. And when you see the patient in your clinic, only twice in comparison to 8 to 10 times, you are for sure more cost effective. And the morbidity of your treatment is decreasing. And the time is also decreasing. So you start now really to fulfill the requirements of your patient. And this is what I mean where we need this new technology. So here, for instance, we could see in the analysis, yes, there is enough bone to place an implant completely into native bone. So we don't need any bone augmentation procedure in this case. We are missing volume. We can compensate this volume in the aesthetic zone, and we know a lot about that, with soft tissue. So now we can place in a case like this, as you see here on the picture, we can place the implant using the 3D technology. We need CBCT to analyze, to place this implant indeed almost, I said almost flapless. There are a lot of incisions, but you don't see them. And we can compensate at the same time the volume by adding connective tissue, and we can take even an impression at the same time. So now you let Mother Nature heal, and you're finished. You can send the data to the lab technician, he can make the crown, and in the second session, you are going to place the final crown. And this is, in my opinion, a big move in the direction we should go on. This is the second session where the patient show up, he gets the final crown, and he was in our office twice. And there, I think we have to think about that. There we have possibility which were open now all of a sudden with this 3D radiograph, that we can achieve that. Even when we go to implant the aesthetic zone, my personal opinion there is we need a 3D analysis before we are going to place an implant there. To place an implant immediately into an extraction socket in the aesthetic zone without knowing the bony structure, which we will see later on when the tooth is out, this is today, in my opinion, something where we have to think about, and using the 3D analysis mandatory. Here, for instance, we extract the tooth, and in the analysis, most of the time, our CBCT look like this. And we see the teeth is completely in a different position than we are going to place our implant. Now think, you have to place, as a clinician now, your implant in this position. This is the right position, what we analyze three-dimensionally. But now you have to do this, taking out the tooth and place your implant into this hole, without knowing where is really the bone. And we all know placing an implant in the aesthetic zone is so mandatory. We have to place it almost on 1/10 of a millimeter precise. And we are not allowed to be too close to the neighboring teeth. We are not allowed to be too deep and not too high, and all this detail. So having this analysis allows me to achieve the best implant position in this area on a better way. And those things don't happen. Once this patient show up and had 2 weeks ago immediate implant placement in the aesthetic zone, and there is no buccal bone anymore, and everything is lost, and the dentist just placed the implants free-handed. And so these things we need to avoid. This then ends up over the years in a catastrophe. And yes, in the aesthetic zone, placing an implant into extraction socket, here we did the same time reconstruction. Then you end up with great results, not only short time. This, for instance, is a case from 2014. And when we look at the patient 7 years later, it looks the same, completely stable, because we planned the case perfect. We placed the implant in the right position, and we knew how this site looked like once we extracted the tooth. And then we can go even a step further. New ideas, crazy ideas. We can, having this situation, a patient who has no bone in the posterior area. Normally, this means for the patient, honestly, a nightmare regarding our treatment concepts we offer this patient. It means for him between 4 to 5 surgery. It means for him a treatment time 20 to 24 months. This is, yes, the concepts are great, and we know a lot about how they work, but in our opinion, this is not the direction we should move in implant therapy. We now need to find ways to treat those kind of patients shorter, less surgery, the same what I just said. And here, for instance, this patient, we finished in 3 sessions. So this patient was in our clinic for 3 sessions. And we needed the 3D technology tremendously. Without it, I cannot do it. So you analyze, you can see 4 or 5 millimeters of bone above the nerve. Now we can augment the bone with a new idea, converting our understanding of the digital world in another way. So now we place the implant above the nerve. So we plan something completely crazy. But this is a help for us to make later on a cut to the bone over the nerve. So being over the nerve, we use the navigation. And then this is the planning. So we plan the implants completely wrong. We don't got to place those implants like this. But we use the technology of this static navigation by being sure to make later on the osteotomy above the nerve away from the nerve. And so we can do this horizontal osteotomy much more predictable. And then we can do this kind of treatment. This is a sandwich technique, or you call it a distraction osteogenesis in one surgery. You move the bone up, you bring the bone in between, and then you let it heal. And you wait 3 months, and the bone is there. And after 3 months, you do that, what you see here. So in the second session, the implants are placed, the impression is taken, and the soft tissue is managed. So at the same time, we manage the soft tissue. So now we place implant, we take the impression, and we manage the soft tissue. And we get a
Markus,
great result.
in this case, were these the horizontally placed implants that you now
No,
take in the second
the
session? That
horizon-
was
let
something
me
else.
go
That
back
was a
a
different
second.
concept.
Yeah, this is the surgery when we augment the bone.
Exactly.
Then, when you have done, I don't want to go too much in detail. You wait for 3 months, then the bone is there.
Yeah.
And this situation is now, after I have 3 months of healing, now I place the implant, I take an impression of the implant, I manage the soft tissue, and now I'm finished. Now I wait 2 months, and this is 2 months later. And the patient gets, after 2 months, in the third session, gets the final restoration on the implant. This is what I want, what I think personally, and we think in our clinic, this is where we have to head to, because this is the expectation of our patient. And we have to start to use this new technology in other ways. It's not only to place the implant perfect. Yes, this is important. I agree with everybody. And for a beginner, more important than for an experienced guy. I agree too. But having now ideas to fulfill the requirements and requests from our patient in another way, this is where we really get something out of it. And this is where I personally even would say, yes, I cannot do these things without a 3D radiograph. This is the radiographical outcome of this patient. And now we are in another situation. Now all of a sudden, we are more cost effective, much more cost effective. We see the patient 3 times. The time is shrinkage from 20 to 22 months to 5 months. I mean, this is another world. And this is because we have this new technology. Because this technology allows us to do now things in a different way. And this is what you also can see in medicine everywhere. By being more navigated, understanding better the site you are going to treat, that you can do it more minimally invasive, more predictable, and I think it's not to stop. But at the end, I don't want to say that for each implant we need now navigation. This depends, in my opinion, also on the clinical experience. If somebody is really a beginner, I would always recommend it. Honestly, even I placed my first implant over 30 years ago, and I have experience. But I like to have navigation. I like to have at least a template, a static navigation. Why? You know why? Because today, when I place an implant in the area, I have a lot to think as a surgeon. How do I manage at the end the soft tissue and the bony situation the right way? Where to place the implant shoulder? How to have at the end after surgery the perfect soft tissue around this implant? And this is not easy. Surgery around implants, even in the functional area, it's not just a cut in the middle, open the flap, and that's it. Place the implant, close the flap back, and that's it. It's much more complicated because the demand and our science has clearly shown we have to create something special around the implant. And I want to give all my emphasis during the surgery for this and not to think about the inclination of my implant. I don't want to take care about that. This is easy. Okay, basically screw in the bone. How much far away from this tooth and what is the inclination? I'm happy to have this done by the software and by my template, and makes my day to do the surgery much more easy. And that's why I even, in easier cases, I could do it without navigation, with my experience, but I like to have it. I do it, honestly, 70% in our clinic navigated. So that's it. I hope I could convince you that, yes, I wouldn't say it's mandatory. Maybe this is too strong, this word. But I think it's opened a new world in implant therapy. And it's not only placing the implant prosthetically, biological, right? It's also new ideas and helping us to move implant therapy in a new direction.
Exactly. Well, thank you, Markus, for this very to-the-point kickoff. Very clear, very exciting cases you bring. Let's see if we can now develop this a little bit further, because for me, it's still a bit of a big gap between 3D radiography, which is more or less a diagnostic tool, towards reducing treatment planning from a 24-month protocol to 3 meetings. So let's help me understand how we get from the tooling to the enormous outcome. First step, basics. 3D radiography is making a 3D scan of the patient, right?
Absolutely.
Compared to X-ray, I guess. That's where we come from in the past.
The 3D, the CBCT is three-dimensional, and in the past we used a two-dimensional panoramic view, and we started to use some measurement on the panoramic view, make some calculation to get the length, how much bone we have available. And today we can do this much more precise.
Exactly.
We can discuss the precision.
And that's where you said the most important thing is once a patient walks in, I better know how much bone there is. I better understand the landscape that I'm operating in.
Absolutely, absolutely.
All right. So that's the diagnostic phase. Then we go into planning phase, and you shared some ideas about I can come up with total new concepts.
I mean, we have actually 3 possibilities. We can do a static navigation, create a template with the software. Then we can do the so-called dynamic navigation, where you are guided during the surgery. This is something it's not so easy as a surgeon to use the dynamic navigation, because you sit here, like I'm here now, here's the patient, and here is my handpiece, and then you look here on the monitor, and then you prepare into the bone like this. You don't look in the side. This is not the normal way we as clinicians work. We see what we are doing, where our work goes in the bone.
Yeah, and even with the offline navigation, you're still, your eyes are where your hands are, right?
In the static one, you are there, like normal.
Yeah.
That's why, in my opinion, it's a little bit easier to use. Offline, online, or better, the dynamic, you stay there, and you really have to trust the computer.
Exactly.
You really need another
And that's an important point. You say you really need to trust the computer. And we talk in this conference a lot about digital workflows, from diagnostics to planning to now also even in surgery. Let's talk a little bit about accuracy. Because technology always comes with error margins.
Absolutely.
We've heard, and there's science about the different margins in the different phases. How about this real-time online navigation during surgery? What kind of tolerances are you dealing with?
So what we have heard and what we know today is, yes, the dynamic navigation, where you have a little bit less parts to play with, you are more accurate. You are more accurate than the static one. This is what the evidence shows us.
Now we're talking about guidance. So you say a static guide. What are the tolerances you could expect on a static guide?
Yeah, you still have, when you look at the software at the end, the company, they don't let you place the implant 0 to the bone. This is too risky, because they know all the failures in the whole technology is between 1 to 2 millimeter.
And that's significant.
And that's a lot.
That's
so
a lot.
If you have 5 millimeter of bone and you want to place a 5 millimeter implant, then you have to go as close as possible to the nerve. There, you cannot rely on all the technology. It's not, you cannot place your implant top of the nerve. This is not possible. There is no technology, even when we go even a step further, robotic one, at the moment when we look at technology, and I personally think it will never happen, because there, the CBCT alone has already failed.
Right? Yeah, so because that's what's happening. There's little tolerances in every step of the phase,
every
which might
step has
add
a
up.
failure. Then you print something, then you have, or in the dynamic you have this handpiece with the guidance to the computer, and in all these parts you have failed.
Yeah.
And so we will never, I'm convinced.
But that's why I'm so curious, because as long as my eyes are where my hands are, I might already, from experience, see, oh, wait a second, I'm dealing here with an error margin.
That's
now you say, I take my eyes out, and I trust the computer.
Very dangerous.
What can you say about the tolerances on this real-time 3D navigation? What do people need to take into account? What is your experience?
Yeah, you mean how better you are with the dynamic one?
Yeah.
You are clearly a little bit precise of what the evidence shows. Maybe 1 millimeter.
Still.
You are still 1 millimeter. Maybe 0.8, but it's still 1 millimeter. And this is a lot in our field. I mean, we discussed today 4 or 5 millimeter implant length. Some company offer you 4 millimeter, some 5. But then you assume you go as close as possible to the nerve. In my opinion, there, it's true, you need to be a clinician. And I like, honestly, in situations like this, it's not only that I have a guide, a template, static, to have the inclination of my implant and the position, but it's also, I'm looking there, when I prepare the hole, I go and look on the monitor, where is the bone? What is the bone looking like on the 3D picture? So what kind of quality of bone may be there? Where is a little bit more dense bone? And for instance, I can look at the top, three-dimensionally, where my first bore goes in. Is it exactly there where I blend it? Then I look and that's what may help me. Yes, I'm there. I'm good. And so I need the 3D radiograph when I do this a little bit crazy.
Is it for you then as a pilot, so to speak?
Yes,
is it the back and forth between the monitor and the patient?
I go back and forth.
And you validate whether that is still correct?
I go to the monitor, I check there, then I go back. Is it really there where I am according to my planning? And this helps me a lot, specifically when I try to go as close as possible to the nerve. There I developed a new technology in the burring protocol. So I do a different burring protocol, what we have learned from the sinus lift. When we do a sinus lift internally, then I go with the small burr till I see a little bit below point. This is the sinus. And then I open first the implant bed with wider burr at the top. And then I go closer and closer stepwise. So I do the burring process when I do an internal sinus lift already different. There I also have to go as close as possible to the flow of the sinus to hit it later on. I do the same thing now today when I place close as possible to the nerve in the lower jaw. I prepare with the 2 millimeter and then I open first. And then I go step by step, widening deeper, deeper, deeper. And then I get better control.
Why, Markus? Why did you decide to start
because
work
then,
like that?
you know, over the nerve, you always find cortical bone, always. There is always a very wide bone. And you can start to see these things as an experienced guy. It's nothing for a beginner, I agree. For a beginner, he should be careful to place an implant as close as possible to the nerve. Don't do that. Don't do that. Then go another way or have the bone augmented or something like this. But if the more experience you get, then you can do that. And you start to, you know what I say is, you start to feel the bone, smell the bone, and you see the bone. And this is important.
And this is something that definitely comes with experience, of
yes,
course.
This is experience. This you cannot...
When I listen carefully, do I also hear you say you often use both a static offline guide and the 3D online navigation?
No, this I don't do. No. I use the static
either
one.
Or.
And the other one is my planning. I have the planning on the monitor.
Yeah.
Because I had to do a static planning to create or to drill or to print my template. So I had to do all the planning in the software, and I have these pictures on the screen beside it. And then I can compare my static planning with the monitor, and then I know where I am. I need it there, for sure.
Now, Markus, you are super excited. It allows you to do a ton of new stuff, and impressive. You say it allows me to really reduce the amount of sessions I need for a patient. It makes it sound like a no-brainer. Everyone, and that's also the title, should do this. It's mandatory. What are some of the drawbacks? When would a clinician be in a position where they say, well, you know what? I stay away from this.
Yeah, I mean, when you have to play, I mean, the more experience you get, I understand. I have a lot of friends, you know, and they come to me and say, come on, Mark, you don't need navigation. You place so long implant, you know exactly how to place an implant. I say, yes, that's true. But those guys, maybe, yes, they don't need it. I would agree. The problem is that everybody judge himself the right way, you know. This is a personal thing. This is maybe even an ethic thing. Do you judge yourself in the right way? Do you really know what is your experience? Maybe somebody said, I placed now 50 implants. Now I'm experienced. Now I can go and make it without. Maybe this is not the right way. This is very difficult. This is an ethical thing. To give here recommendation, yes, I mean, some people are faster. They have better hands, more skill and all the dexterity. Everybody has to find out
basically,
himself.
when I listen to you carefully, these type of technologies based on 3D radiography basically give you better precision, better knowledge of the patient and better accuracy. If you decide not to use it, it's almost a choice where you say, I think I'm better than the technology.
Yes. I mean, better than technology. I mean, look, I also tell you a story. You know, I remember a lecture. I went on a lecture about navigation. And yes, everything was done beautiful. And he did a live surgery with dynamic. So he placed the implant, looking at the monitor. Everybody was excited. And yes, the implant was placed. I tell you honestly, it was placed okay. It was a single, only loss of one tooth.
Yeah, so a
So
relatively
you had
simple
two
case.
neighboring teeth.
Yeah,
Honestly, I would have placed the implant better.
freehand.
Free-handed, 100%. So looking at the end, he was a little bit too much palatal. I could see it right away. You could see it on the monitor, you could see it on during the live surgery. I showed you the picture and said, oh my goodness, this implant is clearly too much palatal. So, you know, when I have a single loss of a tooth, then I have the neighboring tooth, I have the buccal lingual
so much
situation.
reference.
So I'm going to place this, and I have maybe only a panoramic view. I know how much bone is there. So I can place an 8 millimeter, 9 millimeter implant easily in the right inclination. I have all the helps there. I can do that for sure. And then there are many who can do that.
Exactly.
And there it doesn't make sense now to do a 3D analysis and do. Yeah, I would agree with everybody. With 2, it's a little bit more complicated, but still you can solve. But then it gets more and more
The more
complicated.
complex the case, the more useful it becomes.
Absolutely. And in the aesthetic zone, and maybe I can give one hint here during this discussion. That's what I always said when we do socket shield. We're going to discuss a lot about socket shield in the future, also here with the EAO.
Which is a new surgical approach.
New surgical approach. And I always said, don't do socket shield without 3D radiology. You need this. And in this situation...
Why? Because you need to be super precise.
No, I tell you something. This is what nobody understood till today. The 3D radiographs in the socket shield is not only there to place the implant in the right position, like what we always say, what we said now since the beginning. No, the 3D radiographs is the need for designing the design of the shield. This is new, and nobody ever heard about that. I wrote this 1 year ago in my book, in my publication, that the reason of the 3D radiograph for socket shield is the designing of the shield. You know, there's a lot of discussion how thick the shield should be and how long the shield should be. Forget it. You have to design it. When you do socket shield procedure, you have to design it three-dimensionally, and then you have to find ways, and that's the trick. You find ways to anchor your shield with the thread, and then it becomes a much more safer treatment.
Exactly.
So there is a typical example where I would never renounce on a 3D radiograph. This is mandatory.
Exactly, it's mandatory in those cases, and I've been told that this socket shield technique is something new and innovative from your hand as well.
Yes.
And if a lot of people think, what, I've never heard about it, that's because it's new stuff. Eh? You are working on that, you're researching that, and there's more to come from you on that.
Yeah. We need, I mean, it's good that we have new stuff coming.
Exactly.
But then we need also the new technology. The new technology helps us to do these new things.
Final short question before we wrap up this session. I can also imagine, we talk a lot in this Congress later in the next few days about unhappy patients, about communication with patients. Would you say that perhaps the 3D radiography, even in maybe simpler cases, is also beneficial for kind of the administrative legal side of the treatment planning, and also when things happen later on, you have something to lean back on?
This is a very dangerous question. This moves in a direction where we have to be careful, you know. When we start now, this is what the company want. You know, the company who sells you the CBCT machines and all the things, they want that we officially said it's mandatory for each case, and then you are not allowed anymore to place any implant without a CBCT. This could be dangerous, because then it's overtreatment. But when you ask me about the patient...
then it's overtreatment.
Then this could be overtreatment. But when you ask me, it has an effect on the patient. Some patients really want that you show the new technology, and then you say, now we do now a 3D analysis. It's a marketing tool on one side too, because the patient says, oh, he's doing
this. This guy knows what he's doing.
Yeah,
right?
he does 3D, and then I feel this is for sure also a marketing tool, no doubt. And on one side, yes, in certain situations, I say to my patient, here I don't need it. If you want, I do it, but I don't need it. And here I absolutely need it. I need it, it's mandatory for me. And I have situations, which I share with you, where I must have it.
Exactly. So you still decide case by case?
I still decide by case.
Perfect. Markus, thank you so much. Let's wrap up the key take-home messages from this session. First of all, I think the navigation does not just improve the implant position, but we saw also all the other benefits in the treatment planning and protocol. Second thing I picked up is that certain clinical situations can only be solved with navigation. For example, the brand new socket shield technique that you also mentioned and talked about. Number 3, I also hear you say, in the end, every clinician needs to decide him or herself whether it makes sense to use this new technology, right? I see you nodding. And 4, the offline systems, the guides, are at the moment still easier to use?
As I said, as a person, to make this movement,
it's a
for
big
me,
step.
It's very difficult for me. Not looking at the side where I were, just do that and really trust the whole technology. It's not so easy, but you know, younger people may be better in using the new technology than we old guys. We want to see what we do, maybe.
That's a very honest last remark. Thank you so much, Markus, for carving time out of your busy schedule to be here with us for the online delegates specifically. This is the end of our Tell Me More About session. Looking forward to see you next time.